You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 31st, 2026. This week, an important announcement, listener feedback, another failure of left atrial posterior wall isolation, first-line AFib ablation, a revelation on the EAST-AFNET 4 trial, a left atrial appendage closure meta-analysis, and preventing AKI after cardiac surgery. First, an announcement. Next week, I am in Australia, and I'll be giving some lectures at the CSANS meeting, that's Cardiac Society of Australia and New Zealand. Now, by the time I arrive and acclimate to winter in the Southern Hemisphere, I'm not even sure what day Friday will be, so I'm going to take the week off. Consider it my summer holiday, if you will. Now, if you're at the meeting, please say hello. They've assigned me 15 lectures, so I'll be busy. All right, next is some listener feedback from Dr. Hakun Ilu Hansen, and I hope I got close to that. Dr. Hansen is a Norwegian doctor, and he writes, Dear John, regarding your discussion of the DAPT MVD trial, which was an RCT of 1 year of DAPT versus 2 years of DAPT after stenting, and it found that in a Chinese population, adding a year of DAPT reduced a MACE endpoint but did not increase bleeding. Dr. Hansen notes that I mentioned the surprisingly high rate of ischemic stroke, which contributes to the MACE outcome. And I made that comment because most of these MACE outcomes that include MI, stroke, CV death, stroke is usually the least common endpoint. Dr. Hansen writes that one possible explanation may be the substantially higher prevalence of intracranial atherosclerotic disease in the Chinese population. I see intracranial disease is estimated to be 3 to 4-fold more common among Chinese than among Caucasian population, and it accounts for approximately 30 to 50% of ischemic strokes in China compared with around 10% in European populations. Given that the study enrolled patients with established coronary disease, which is often associated with atherosclerosis and other vascular beds, it is plausible that intracranial atherosclerosis was also highly prevalent in the study population, and this may, at least in part, explain the relatively high incidence of ischemic stroke observed in the trial, and this is why I love listener feedback, because I didn't know this, maybe you didn't know this, and now we all know this, so thank you, Dr. Hansen. All right, first topic today is another failure of posterior wall isolation during AFib ablation, and what a saga this has been. Most of you have seen the post-ablation pictures where there's two wide circles where have been ablated around the PVs and PV antra area. And in the middle of these circles is a strip of posterior wall, usually this nice purple color. Some experts consider this area, the posterior wall, an extension of the PV musculature, and thus is arrhythmogenic. And there are, of course, many epicardial connections along the posterior wall, and the esophagus sits in close proximity to the posterior wall. So there's this idea of making two lines above, the roof line and the floor line, and eliminating all of the electrograms from the posterior wall, and that, of course, will reduce AFib. This is the thought, because if this is extension of the pulmonary vein musculature, then ablating it would be good. And PFA has made it super simple to do this because you don't have to worry about damaging the esophagus, which can lead to death. So in the RF era, you couldn't just willy-nilly ablate in the posterior wall because you would heat the esophagus and increase the chance of the patient having a fatal complication. And some of these patients are 40 and 50-year-olds, and fatal complications are never events. Yet, there have been a slew of trials studying the addition of posterior wall isolation to PVI versus PVI alone. The largest and maybe most important trial is the CAPLA trial from the Melbourne group, and this randomized 338 patients. The longer procedure led to no signal of benefit in terms of less AFib. Last month, I covered the larger Japanese cornerstone trial, and this was PVI plus posterior wall isolation versus PVI alone in patients who have persistent AFib. Again, no benefit was found. This week, Heart Rhythm has published the pivotal IDE trial of cryoballoon PVI with posterior wall isolation versus pulmonary vein isolation alone in patients with persistent AFib. Nearly a third had to have RF to complete the posterior wall isolation because the balloon did not work. But again, in this smaller trial, just 150 patients, there was no statistical difference in AFib recurrence. So now 3 trials where we tried adding posterior wall isolation and it didn't work. Now, as I said in June, when the negative results of Cornerstone came out, this story tests our beliefs versus empirical data. Namely, it is easy to believe that posterior wall isolation should help. For instance, the myocardium there does seem to be erythromagetic. It does not contribute to cardiac contractility, and now with PFA technology, it's super simple to isolate, at least initially. Whether it's durable or not is another question. So in patients with persistent AFib, it seems unlikely that PVI alone is enough. And I say that, but then you think to yourself, well, what about the STAR-AF2 trial, which found no benefit to adding adjunctive lesions beyond basic PVI and still improves outcomes? And yet now we have 3 RCTs that specifically find no benefit to posterior wall isolation. The proponents of posterior wall isolation do make strong points, however. They say that thermal ablation, whether cryo or RF, does not often lead to durable posterior wall isolation. Yes, they say you can obliterate the electrograms acutely, but then when repeat studies are done, there's a very high connection rates of the posterior wall, and this is likely related to the epicardial connections. The question I think now for electrophysiologists is whether pulse field ablation posterior wall isolation will prove effective. Many studies are ongoing, and in a year or so, a story will emerge. My guess is that there may be some small benefit in patients with advanced forms of AF, but as I said in June, in my center, we use a dual lattice tip 9mm PFA ablation catheter. And when you do PVI with that catheter, the lesions are so big, it is hard not to do posterior wall isolation because the circles basically meet on the posterior wall. So it has become my routine mostly to include posterior wall isolation. However, I had a case recently where the PVs were firing in bursts of AFib, and in this person, I did very tight circles just close to the PVs. But you actually, with these PFA catheters, you actually have to try to not get into the posterior wall because the lesions are so much bigger than with RF. Obviously, we need more data on this specific question, and of course, more data on the pathophysiology of AF. I have said it many times. Once more, I'll say it again. The next big advance in atrial fibrillation is not going to come from an EP lab, but from basic science labs, where, for instance, maybe someone can tell us why people have AFib and where we should ablate in certain patients and not in others. All right, in a related topic, first-line AF ablation, let me speak about one new study published and a discovery about a second one, a big discovery about a second one. Heart Rhythm Journal has published an observational study using an insurance database to compare first-line AF ablation versus antiarrhythmic drugs. The primary endpoints were hospitalization for atrial arrhythmia or cardioversion. Now, insurance databases are big studies. The comparison group was 2,700 patients who had catheter ablation versus 22,000 who had antiarrhythmic drugs. In these patients with newly diagnosed AFib. Now, of course, these are unequal groups that are non-randomized, and so the authors do propensity score matching and inverse probability treatment weighting and all of these statistical techniques to try and reduce baseline differences. And what they found is that patients undergoing catheter ablation as first-line therapy had a 48% lower risk of hospitalization for atrial arrhythmia, a 52% lower risk of cardioversion, and all of these numbers were statistically significant. And the authors concluded that first-line catheter ablation for paroxysmal and persistent AFib is associated with significantly lower risk of hospitalization for atrial arrhythmia, and this is consistent with the results from trials and current Class 1 guideline recommendations. So my comments and some thoughts on limitations. I'd like you all to read the study and try to find all the limitations, and good luck with that because there are so many. This is an incredibly flawed study. First of all, and I'm not sure how this gets into Heart Rhythm Journal, 3 of the 5 authors are employees of Johnson & Johnson, who are the makers of AFib ablation catheters and mapping systems. Second, of course, ablation patients were younger, more often male, better educated, higher income, lower comorbidity indices, and lower CHA2DS2-VASc scores at baseline. And clearly, the patients whose doctors chose to do first-line ablation were healthier than those who received antiarrhythmic drugs. They're different patients. Now, the authors attempt to do post-comparison matching on covariates, but you can only adjust for things that are in a data sheet. There are many factors that do not enter the spreadsheet and data sheet that are important. And always remember, this is one of the most important messages of this podcast, is that randomization balances known and unknown covariates and factors. Now, there's also asymmetric safety outcome windows. After catheter ablation in this observational study, only 30 days, but with antiarrhythmic drugs, you could have a complication over a full year, which obviously gives more time to accrue complications in the antiarrhythmic drug arm. Now, the first thing that comes to mind is hospitalization for rapid left atrial flutter 2 months after an ablation. That would not have been counted in the catheter ablation arm. Another problem is that there's likely immortal time bias built into the catheter ablation arm. People with the AFib in the catheter ablation arm had to wait to see an EP, right? Had to get on a schedule, and all that time had to remain free of bad events, while those on antiarrhythmic drugs simply can get started onto antiarrhythmic drugs by anyone, and this bias is again towards catheter ablation. Finally, authors say that these findings are consistent with results from randomized controlled clinical trials and current Class 1 guideline recommendations. And I want to now present a new discovery about the EAST-AF trial. EAST-AF was published in New England Journal of Medicine in 2020. My friend and colleague and one of the smartest thinkers in all of cardiology today, Dr. Andrew Foy, pointed me to something about the EAST-AF trial that I had missed all these years. It's really important, and I wanted to mention it here because EAST is such an influential trial in the AFib world. Now, first, a background. New England published a study in 2020. It was an international, German-led, pragmatic trial of early rhythm control versus rate control in patients with new AFib. Early rhythm control included antiarrhythmic drugs and ablation, but importantly, less than a fifth of patients had ablation. This was really antiarrhythmic drugs versus rate control. The primary outcome of CV death, stroke, heart failure, ACS was reduced by a statistically significant 21%. The absolute risk reduction was small, 1.1%, leading to an NNT for a MACE event of 91. The second primary endpoint of days in the hospital were similar. Other secondary outcomes, such as quality of life, LVEF, were also not different, similar. Now, EAST has led to great enthusiasm for early rhythm control. Its results differed from the AFFIRM trial of 20 years ago. And that AFFIRM trial police found no difference from rhythm versus rate control and a trend towards worse outcomes in rhythm control arm. EAST has influenced guideline writers in North America and Europe, and essentially the idea has been proposed and really accepted that AFib is progressive and earlier intervention is better. Early rhythm control also got a boost from the early AF trial from Canada, which found that ablation was superior to antiarrhythmic drugs. Now, I have been critical of EAST on the grounds that A, it's hard to understand a priori how an antiarrhythmic drug trial could lead to better MACE outcomes because antiarrhythmic drugs have never been shown to improve clinical outcomes in any trial. And B, the early rhythm control arm of this trial received many-fold more medical interactions than rate control, as every time a person in that arm felt symptoms, they transmitted an ECG to a clinician and had an interaction. C, the difference in sinus rhythm, and you have to look at the supplement for this. 60% of the rate control arm were in sinus rhythm, 80% of the rhythm control were in sinus rhythm at 2 years, and so that 20% difference, I find it very hard to believe that such a small difference in sinus rhythm between the groups could drive clinical outcomes. So taken together with the differences in patient interactions and the trial procedures, I believe strongly that performance bias was the main reason for the benefit, not anything to do with rhythm control. What's more, the EAST trialists hid the adverse effects of rhythm control because they double counted death and stroke as both primary endpoints and adverse effects. Had they not then done that, the adverse events of special interest would have been far greater in the rhythm control arm, 3x to 6x greater. Well, what's happened last week during our cardiology trials Substack podcast, Dr. Foy pointed me to something even more concerning about EAST. It's figure 1 in the trial diagram. Go look at it in New England. That shows that the authors of EAST screened 2,810 patients for eligibility and enrolled 2,789, meaning they enrolled 99.3% of the patients that they screened, which is shockingly high. It's high because recall that AFib is one of the most common diagnoses in the hospital and emergency departments. AF comes in hundreds of different varieties, yet 99.3% of patients they looked at were EAST eligible. Also, keep in mind that EAST recruited from 135 sites, presumably big AFib centers in Europe, over 5 years. So that's 20 patients over the trial, or 4 patients per year. 4 patients per year. Foy was worried, and I can't disagree, that if you recruit only 4 patients per year of the 1,000+ AFib patients that get seen in a hospital, then it's highly likely that early rhythm control proponents are cherry-picking patients most likely to benefit from early rhythm control. It's not necessarily nefarious, it's just you're a proponent of early rhythm control, and you're looking at patients, and you're like, that patient looks good, let's put that person in the trial. And then that patient, no, that we can't put that patient in the trial, they're not going to do well with antiarrhythmic drugs. And so you cannot have a trial where 99.3% of the patients screened are enrolled. That means that somebody's been highly selective. So you can add this to my criticisms of the EAST-AF trial. And so my summary of this whole idea of early ablation situation, I remain convinced that there is widespread overuse of AFib ablation in the U.S. community. It was bad before PFA, but now with PFA, it's even worse. These single-shot PFA devices, which allow you to do AFib ablation in 30 minutes, has created this irrational exuberance for AFib ablation. Another force in the U.S., of course, is that payers have decreased reimbursement for the procedure, so the only way to maintain your salary is to do more procedures. Inappropriate AFib ablation includes doing patients without having a calming off period to see if the AFib will dissipate. That's one of the problems with early rhythm control, is if someone has 2 episodes of AFib in February and you do an ablation in March and they don't have AFib in July, you don't know whether the ablation was successful or that it was just 2 episodes in February. Inappropriate AF ablation also includes doing it before a trial of weight loss and lifestyle factors was done, or doing patients with only one episode of AFib, or extremely low burden, or totally asymptomatic AFib. I also see patients who have had AFib ablation who have extreme frailty and multimorbidity. Now, to be sure, it is true, I do more AFib ablation now than I ever have, largely due to PFA's lower burden to the patient. And PFA allows a greater ability to tackle left atrial flutter, which we may not have done with RF in the past. But the conservative approach to an invasive procedure remains crucial. We are doctors, not proceduralists. The patient who is 150 or 200 kilograms or has a hemoglobin A1C of 10 does not belong in an EP lab. The patient with 1-hour episodes of AFib once every year does not belong in an EP lab. As a profession, we need to promote wise use of this procedure. As for the early approach, I am not advocating waiting 5 years to ablate, but there are many weeks and months available to work on upstream causes of AFib and to educate patients with what is often a lifelong condition. I think it's really important to take time to remove fear of AFib before proceeding with an invasive procedure. All right, next topic is a left atrial appendage closure meta-analysis. Now, with the recent publication of Closure AF and Champion AF, there have now been 6 RCTs comparing percutaneous appendage closure versus oral anticoagulation in patients with AFib. There's PROTECT, PREVAIL, PROG 17, Option Closure, and Champion. The journal EuroPace has published what I think may be the best or first meta-analysis of these trials. The 6 trials enrolled about 7,000 patients, and the 3 main findings are simple. Ischemic stroke or systemic embolism, that which the device is supposed to prevent, was 41% higher with left atrial appendage closure. Relative risk 1.41, 95% confidence intervals 1.07 to 1.86. So the range was from a 7% higher risk of ischemic stroke to an 86% higher risk of ischemic stroke. Major bleeding was not different. Relative risk 0.91. Confidence interval 0.77 to 1.08. Hemorrhagic stroke was very small in numbers, not different. Although the relative risk was 0.58, the confidence intervals go from 0.28 to 1.17. And notable for the fact that there were only 60 events in 7,000 patients. Obviously, these are why the confidence intervals were so wide. Notice that I did not tell you about overall mortality, CV mortality, and non-procedural bleeding because these are the wrong endpoints. Wrong. Double wrong. The LAAC 3 trial showed us that surgical appendage closure with oral anticoagulation reduces stroke but does not affect mortality. Of course it doesn't because stroke is such an uncommon cause of death. Now, the meta-analysis authors include CV death in their summary data, and I don't think that's a problem because all the trials included it. But we can ignore it because it's noise. We also can ignore non-procedural bleeding because patients cannot exclude bleeding from the procedure. Therefore, the summary of this is easy. Compared with oral anticoagulation, left atrial appendage closure is clearly an inferior strategy. There's nearly a 2x higher rate of ischemic stroke with 0 advantage for bleeding. Left atrial appendage still requires a patient to take an antithrombotic pill. Now, it may be aspirin, but it is still a medication that they have to take. Since doctors are not in the business of suggesting inferior treatments, I cannot see why there would be any reason to do shared decision-making in patients eligible to take a DOAC. We don't offer medications or procedures that are inferior to people, especially when ischemic stroke is a potential outcome. Now, for patients who have strong reasons not to take oral anticoagulation, some would say that appendage closure is an alternative. But, there is not one shred of RCT data suggesting this is beneficial. No patients like this have been in RCTs. Observational studies of these patients are uninformative due to bias. I would go so far to say is that if you believe that appendage closure is better than nothing for these truly ineligible patients, given the total lack of benefit seen against oral anticoagulation, you must only be able to cite religion or faith, not science. In these complex patients who have oral anticoagulation ineligibility, let's say from end-stage renal disease or other bleeding issues, low platelets, hematologic disease, in the best case, an appendage closure device only mitigates one of many causes of stroke, if it could even do that. But let's just say it could. It's only one potential cause of stroke. These patients who are sick enough to be anticoagulation ineligible have many competing causes of stroke. They start the benefit-harm gamble with a finite procedural risk. Let's say the procedural risk is 2 to 3%. Now, that device has to reduce outcomes by 2 to 3%. The patient has to live many years to get this benefit. Also, keep in mind, please, what happens to the patient who bleeds every time they take anticoagulation, who then has a device-related thrombus, which occurs 3 to 5% of the time? Now, these patients have to take a drug which causes bleeding. You have to give them an anticoagulant or they will have a stroke. Or you have to have surgery to remove the device. you have harmed that patient clearly. I think the meta-analysis so clearly lays out the lack of benefit of this strategy. Never in my career of 30 years have I seen a procedure be so embraced with so little data. And the more evidence we get on appendage closure, the worse it looks. All right, next topic is prevention of AKI after cardiac surgery, the Mercury 2 study. Now, here's some basic facts. One of the major complications after cardiac surgery is kidney injury. You definitely want to avoid this problem. Patients are now told, at least in my hospital, to hold their SGLT2 inhibitor before surgery because you want to avoid the problem of stress-induced non-diabetic ketoacidosis. This week, JAMA has published the results of the Mercury 2 trial of using 4 doses of dapagliflozin beginning the day of the non-emergency cardiac surgery and continuing through post-op day 2. The primary outcome was between group differences in AKI, acute kidney injury. Now, one problem I will come to is the definition of AKI. Now, the words AKI sound bad, right? Acute kidney injury. Yes, we want to avoid that. But the definition in this trial was defined as an increase in serum creatinine level by at least 0.3 milligrams per deciliter, a 1.5-fold creatinine increase, or a urine output less than 0.5 milliliters per kilogram per hour for 6 to 12 hours during the first 7 postoperative days. The trial was conducted at the UMC Amsterdam, one of the most impressive hospitals I've ever visited. The authors screened 2,500 patients for eligibility, and they didn't enroll 99.3. They enrolled 778 patients. The baseline eGFR was 79, and compared with placebo, here are the results. Dapagliflozin reduced the incidence of AKI 28% versus 52%. That's a relative risk reduction of 46%. Hazard ratio 0 or relative risk 0.54 with highly statistically significant confidence intervals. The incidence of AFib was similar. The incidence of reoperation was similar. And only one patient in the DAPA arm had ketoacidosis, and the authors concluded, quote, in patients undergoing elective cardiac surgery, 4 doses of dapagliflozin beginning the day before surgery reduced the incidence of AKI during the 7-day postoperative period. My comments. This looks to be a well-conducted trial. It's non-industry based. It's attempting to answer an important clinical question that heretofore was not known. In fact, SGLT2 inhibitors are now recommended to be held before surgery, and here's a study looking at giving them and may have protective benefits. The results are definitely positive, but I see some nuance in the interpretation based on the choice of endpoint. Always look at endpoints. Here, I don't want to make any stray nephrologist unhappy, but I'm a bit old school in my assessment of kidney injury. And the change in creatinine of 0.3 milligrams per deciliter or 1.5x hardly seems worrisome. For instance, a creatinine that goes from 1.0 to 1.3 or 1.0 to 1.5, which would meet this criteria for AKI in this trial, is something we see all the time when you're adding an ARB or an MRA to patients with heart failure, for instance. We see these things and we watch it and we tolerate it. In the patients who just had 3 hours of heart surgery, I have trouble worrying about a creatinine that goes up a few milligrams per deciliter, a few tenths of a milligram per deciliter. In fact, in the supplement, the authors show that if creatinine was the only criteria for AKI, there would be no difference in the DAPA or placebo arm. Most of the AKI was driven by lower urine output. And again, please don't get mad at me, but measuring urine output over 6 hours seems like largely a very surrogate measure that few patients would care about. I mean, if I'm post-cardiac surgery and I haven't made any urine in 6 hours, I'm not really worried. We don't worry about people who don't make urine for 6 hours because in the 7th or 8th hour they may make urine. Kidney injury of the kind that I was used to seeing years ago. Patients who needed dialysis or had a creatinine greater than 3 or anuria for a day, that occurred in only 3 patients in the DAPA arm versus 1 in the placebo arm. So way too events of this so-called stage 3 to make any call. The authors say that the trial was not powered for that. One interesting finding, though, and potentially positive thing, is that the kidney disease improving global outcomes, or the KDIGO criteria stage 2. Now that's creatinine 2.0 to 2.9x greater than baseline, or urine output less than 0.5 milligrams per kilogram per hour for greater than 12 hours, was 67% better with DAPA than placebo. So that's an interesting signal. This is a nice trial. It's also plausible. But the trial is small and it has selected non-emergent CABG patients. But surely there does not seem to be a need to hold these agents before surgery. Whether there is a substantial enough benefit to warrant the extra work of giving this medication or mandating this extra medication on a wide scale, I think would require a larger trial, perhaps with more serious endpoints than just class 1 AKI. You'd want to show that more important kidney outcomes were improved by DAPA. I could see a registry-based trial or even a cluster randomized trial where centers are randomized, just some bigger and confirmatory data. But when I read trials like this, I am inspired that there is still people out there interested in answering important questions with trials. Kudos to the UMC Amsterdam team. Okay, that's it for this week in cardiology. Remember, next week is summer vacation in Australia for me, and then I'll resume the week after that. As always, I appreciate that you listen. Thank you. And remember, if you like the podcast, take the time, give us a rating, write me a review. If you have some question or concern, or I said something wrong, please send me a note and we'll do listener feedback. Until 2 weeks, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.